morning friends, welcome you all to Megagen Online Education. Let me introduce you to our midnight knight, Dr. Sejin Chandran, our oral and maxillofacial surgeon and oral implantologist, who has a keen focus on digital protocols in implantology and surgery. A leading practitioner and mentor to many of us. He is also the director of Kamala Dental Super Specialty Hospital, India, a chief trainer for Institute of Implants and Clinical Dentistry. He is also the joint secretary and editor for Indian Academy of Aesthetic and Cosmetic Dentistry. Today he will be discussing a combination of protocols that can be done in a single visit, leading to reduced chair time. Over to you, doctor.
Thank you, Dr. Jency, for your kind introduction. And let me welcome you all to this online session from MINEC and Megagen. Let me appreciate Team MINEC for having wonderful 2 sessions of clinical discussions and lectures from reputed clinicians worldwide. We all are facing a deadly pandemic, and dentistry and implantology is in a standstill situation. We clinicians are pushed to a low profile practice or almost nil practice from last few months. But let us face this with a sweet smile. When I am talking to you people today, my hometown is in triple lockdown with the highest number of COVID-19 cases all around. As we live in this faster world and where no one is ready to wait for long duration to get their treatment completed, let's see today how we can reduce the number of visits and how we can make implantology more faster and predictable. We clinicians are often very skeptical about going faster because we are much worried about 2 major things. One is aesthetics and another one is function. When we have to gain these 2 parameters, you have to understand one thing. Aesthetics is never by chance. It is by choice and design. Some of the options came into my mind when I thought about faster solutions were the implants what I placed in extraction sockets and given a dual zone grafting and immediate temporization. Second was giving an ideal placement of implants with software based solutions and giving the same accurate planning into execution by using guided surgeries. Another option is to give short implants and avoiding grafting solutions, thus reducing the total duration of treatment.
Doctor, why do you prefer placing implants in extraction site rather than healed? Is there any parameters in taking such a decision?
As we know, when we extract and wait, we lose the entire volume of soft tissues and hard tissues. And in aesthetic zone, it is a total disaster. When I have some root stems left in the anterior region, it is a blessing, and I will say the retained root stems or fractured roots, they retain the bone all around, and that is the most advantageous thing in retaining the contour and aesthetics. Now let's see how we go about with a traditional implant based solution aiming at aesthetics and function, that we extract, then we wait for the socket to heal, then we do some ridge augmentation or the socket preservation if needed, then we place the implant, wait for a longer time for its integration, then we do the second stage uncovering, then we try to sculpt the gingiva. That takes a longer time, months together. Then we go about taking the final impression for a better aesthetic restoration. But is there a shorter way of doing it? Of course, yes. That is by clubbing the extraction, socket grafting, temporization, and doing a dual zone emergence profile and giving a good emergence in very short time, that is in a span of 2 to 3 months, But even during that time, the patient is left with an anatomical temporization, most of the times in anterior with non-functional loading. The most important parameter in decision of whether to go immediately after the extraction with the implant or not is knowing the three-dimensional bony and soft tissue architecture of that socket. It is possible only by examining the three dimensions in CBCT, that is axial, coronal and sagittal. By examining these sections, we will come to know whether we need to go for the grafting or not, or whether we are going to get adequate primary stability in these scenarios. Now, I will tell you the sagittal section is the most important one, and that gives me a guidance to decide the future trajectory of my implant. And it clearly gives me an idea about the residual labial bone thickness and the soft tissue around it. In today's discussion, let's see how we place implants in extraction sockets of anterior region and in posterior region. In taking decision whether to go for immediate placement or not, I followed Dennis Darno's classification that he gave way back in 2007. And then we decide what type of socket we have with us. He classified the sockets into three major types. Type 1 with adequate soft tissue and adequate bone level in the labial side. And again, the second type where we have adequate soft tissue and a deficient bone level in the anterior region, that is in the labial side. Now, the third type is where we have complete recession exposing the root surface, that is bone level and the soft tissue level is inadequate. The second scenario is often very confusing. That is, we will have adequate soft tissue, but after doing extraction, there will not be any support for the soft tissues and we will be left with the bone at a different level. That will lead to a sudden collapse and a recession in the anterior region after the extraction. It's my habit to probe the extraction socket all around with a periodontal probe and to see the continuity in all possible directions in an extraction socket. The bony architecture is really felt than imagined.
It was in 2017 that Howard Gluckman gave us a detailed classification for anterior extraction socket based on CVCT findings in radial plane. I had an opportunity to meet him in Miami 2018.
The sagittal anatomy purely depends upon the position of the anterior teeth, whether it is proclined or whether it is retroclined or whether it is occupying the central position in that sagittal anatomy. According to this, the thickness of the labial bone varies, and that is the key factor in deciding whether to go for extraction and do the placement or whether to perform a partial extraction therapy. Now let's see a clinical scenario where we have a type 1 socket and this patient reported to us with a fractured central incisor, and by clinical examination we thought it is a vertical fracture, but the CBCT section revealed that the vertical fracture is limited to its coronal part and the root is intact.
CBCT section revealed a type 1 socket and there is adequate bone and soft tissues in the labial side, but with a tear in the free gingival margin. After extraction, the implant was placed in the planned trajectory with adequate primary stability and the socket was grafted and soft tissues were secured very close to the anatomical temporization. After 2 months, the gingival margins were reassessed and were equalized by gingivoplasty using laser. I have 3 years follow-up of this case with the stable gingival levels and bone levels. You have to understand that the time taken was only for soft tissue sculpting and not for osseointegration and socket healing.
Doctor, when do you prefer a root membrane technique and why?
Root membrane technique is my preferred choice when I feel the labial or bundle bone is less than 1 millimeter and the gingival phenotype is very thin. And I do this when I think the root is ankylosed or the extraction is going to lead to severe loss of soft tissue and bone. In this particular case, when the patient demanded an immediate solution in a daytime, the choice from my side was a root membrane technique. He presented with an excellent gingival contour, gingival zenith, interdental papillae, and an endodontically treated root stem with a failed coronal restoration. By doing partial extraction therapy, we leave a labial fragment of a root without disturbing its periodontium, assuring adequate blood supply to the thin bundle bone from its labial tissues, periodontium, and from the underlying bone. Instrumentation of root membrane technique is awesome and it helps in a predictable and systematic protocol for root division and assuring an accurate placement of implant to give excellent aesthetics and function. Thanks to the inventors and Team Megagen for this wonderful armamentarium. Let us see this clinical sequencing and an excellent aesthetic outcome with root membrane technique.
Doctor, do you place implants in immediately extracted posterior sockets? And do you follow the same criteria?
Yes, Dr. Jensi, it is possible to do the implants in the posterior extraction sockets also. Let's see how we make it happen in the posterior extraction sockets. For the posterior sockets, even for this, I consider Dennis Turner's classification. He classified the posterior extraction sockets into 3 types. Type A is where we have adequate bone to encase an implant in the interradicular region. Now, type B is where there is no adequate interradicular bone to encase an implant completely, but after placement, the threads will be exposed to an empty socket walls. Type C sockets are basically wider sockets due to convergence of roots or otherwise loss of septum during extraction. In this type of sockets, we tend to use larger diameter implants. Nowadays we use larger core diameter implants, especially when it is in the second molar region. Such implants get engaged to the labial as well as the palatal cortex or in the lingual cortex and give adequate stability. Dual zone technique can be employed using wider healing caps or customized abutments.
Now let's see what are the factors influencing the success of immediate placement in extraction socket. I will say that it is mainly 3 factors. The first, the bony architecture of the socket after extraction. Second is the implant design and the primary stability that it offers. And the third, the soft tissue, quantity and the quality.
When we have to place implants in deficient bone or compromised sockets, we prefer an implant system that offers high primary stability. The unique design of any ridge offers the same. knife edge design, progressive thread pattern, increased thread depth, all these make any ridge implant system as my first choice in extraction sockets. Due to increased primary stability and early osseointegration, because of enhanced surface treatment called as XPEED, that is SLS surface coated with calcium ions, will provide these implants early integration and reduced healing time. The latest generation any-ridge implants are available in different core diameters too. Increased core diameters will have lesser thread depth. The increased depth help in gaining better retention in softer bone. Increased core diameter with lesser thread depth is used in areas where the implant is subjected to a greater occlusal load.
Doctor, why do you choose guided surgery in most of the cases? What are the advantages in selecting this protocol?
It's not consistent that our hands will deliver the same results as we expected or planned three-dimensionally in a software. Guided is the option to get consistent results in a very predictable way, and that is the way to future implantology. It reduces the chair time to a minimum duration, that is a longer time spent in the planning and a lesser time for the execution. Guided surgeries offer a high-end accuracy when it is done very systematically and respecting its protocol. We can start with the surgery soon after the patient accepts our treatment protocol. It takes only a few hours to do a digital planning and then to create a stent out of it by 3D printing. Digital protocol help us in achieving better results by adapting a top-down or a prosthetically driven implant placement, resulting in highly accurate and parallel implants offering axial loading. A virtual patient was created in R2Gate software, merging hard tissue and soft tissue profile with 1:1 accuracy, followed by an implant placement done with ideal parameters kept in mind. In this case, prosthetic stage was done in a fully digital way after soft tissue emergence created using customized healing abutments, taking only 2 weeks time. Now have a look at the beauty of implant placements in the anterior region in the most accurate positions and good parallelism using a fully digital protocol. Implant placement, dual zone concept, all done in a fully digital way, I could deliver this temporary prosthesis in an hour's time.
There is always a demand for immediate aesthetic and function. Now the question is whether to give a temporary solution or to give a final prosthesis in one go. There is nothing like if you can give a permanent prosthesis in the first day itself. It is possible only when we go completely digital and using CAD/CAM milled prosthesis that is kept ready in advance to give a solution in one day.
Doctor, I know you place shorter implants in deficient bone. What are the parameters you consider in placing them?
Yes, Dr. Jensi, first of all, many clinicians never accepted short implants as a therapeutic option and were very skeptical till recent years. But there was a consensus on the same in 2015 in European Association of Osseointegration Conference. They accepted short implants as a therapeutic measure with a few guidelines and found the success rate more than 95%. Now the question is, can we use them in posterior maxilla to avoid sinus lifts and extensive bone augmentation demanding longer time for adequate remodeling and secondary stability?
Posterior maxilla is always a challenge, and to give immediate solutions in the posterior maxilla is much more challenging. According to this paper, any implant length which is completely inside the bone less than 8 millimeter is considered as short implants. So anything of 8 millimeter, 7 millimeter, 6 millimeter or less than that is considered as short implants. Now, in this clinical scenario, there is residual bone height only 7 millimeter. Question is whether to go for a sinus lift and place a 10 millimeter implant or to use wider implants with lesser height. In this particular case, I used an implant from Megagen Anyrate that is 7 millimeter height, that is special 7 implants from Megagen, and I could get adequate primary stability and I could proceed to the loading after 3 months' time.
Dear friends, now let me give you few cardinal rules in using short implants. We should never compromise on the length and diameter of the implants unless otherwise it is highly demanding. And use short implants as a single tooth option only when the edentulous area is guarded by natural teeth, that is anteriorly and posteriorly there should be natural teeth present. Whenever you use multiple short implants, try to splint them and avoid short implants in the distalmost area of arches as a single tooth replacement option.
Now let's see where we have to avoid a short implant. I strongly recommend not to use short implants in the distalmost single tooth scenarios. In such scenarios, my choice is to go for sinus lift and then to place regular length implants. In this particular case, we should augment to a greater height of 78 millimeters, and with accurate planning and using a surgical gate and with the depth controlled drills, we could gain an access as close to the sinus membrane, and a bone added osteotome condensation was done, that is the direct manipulation of membrane, and we did the placement of implant with more than 10 millimeter length. When multiple short implants are given, it's always mandatory to splint them together when we immediately load them. I usually do this in my full mouth or full arch solutions, and I get adequate stability and I reduce the treatment time to a greater extent because I avoid extensive grafting procedures.
So, what treatment protocol you consider as successful one?
Being faster doesn't mean that we have to run away from our criteria for success. As I told you, the most important aspects we keep in mind is one is aesthetics and another one is function. Being faster, as we all are very skeptical about whether we will have the same parameters retained for a longer duration. Implant survival and implant success are two different aspects. Implant survival, of course you will get it with our regular protocols. But the criteria for being called as a successful implant is changed. Actually, in 1986, Albertson's criteria was evolved, and in that, up to 1 millimeter bone loss in 5 years' time is considered as normal. But it is not the same anymore. Now we have better concepts, better designs. That time, the study was conducted using most of the time with platform matching and cylindrical implants. Now we have platform switched and subcrustally placed bone level implants, and we have biological connections designed to give good emergence profile and with zero bone loss in the crustal level. When you call it as a zero bone loss, Thomas Lingavicius and team gave us a clear criteria. His work from 2008 to 2019 with a series of publications
Clearly demonstrated that it is possible to achieve crustal bone loss as minimum as 0.2 millimeters, that is almost zero, even after 5 years of loading. He suggested few parameters to achieve the same. 1. Subcrustal placement and adequate bone volume all around the implant. Second, the platform switching in implants. Third, a conical connection with minimal micro movements. And the most important, a thick biological junction with adequate vertical and horizontal tissue thickness and keratinized gingiva all around. If we maintain all this, we are sure of achieving almost zero bone loss in long term.
zero bone loss and soft tissue and hard tissue positions maintained for more than 5 years duration. There are times I do wait. I don't wait for the implants to be placed. I place my implants in most deficient bone scenarios and I augment because I have highly stable implants with a good primary stability. If the implant is stable, it will integrate. And if the bone graft is given and if that is stable, there will be adequate bone growth around the implant. There will be a bone remodeling, and at the same time, if there is adequate tissue thickness, it will protect the bone beneath. I do wait when I don't have adequate tissue thickness. Have a look at this Palacis technique where I have transferred the keratinized tissues from the buccal side and I moved it to the interdental areas, and after a limited time of healing, I changed the regular abutments to a customized abutments and I gained good emergence and good tissue thickness. The end result of such good tissues around the implant is a stable crustal bone. And I am evaluating this case from last 3 years and the bone level is the same. I hope whatever protocols we discussed today enlightened you all about the need to go faster, but to stick on to the basic principles. We can go faster by incorporating more implants in immediate placement way in fresh extraction sockets, and we can have very accurate ideal positioning of implants. Thank you, dear friends, for a patient listening, and thanks to the entire team of Kapila Dental strongly giving me support for thriving for excellence in every clinical scenario and for this wonderful presentation. And thank you, Dr. Jensi, for having a wonderful interactive session, and hope you all enjoyed the same.
Thank you, Doctor, for giving us a wonderful and learning session for all of us. Thank you.